Bismillah ar-Rahman ar-Rahim. Welcome to this new meeting of Egyptian Society of Nephrology and Transplantations, continuous medical education meetings in our usual date of Wednesday, 9 p.m. Today we have a very important topic that we usually face in our daily practice. We are usually asked about how to deal with a patient coming from surgery, how to deal with a patient going to surgery. And this is about our topic. And this meeting is special in many, many aspects. This meeting is guided by two nephrology ladies, two big nephrology ladies. And we have many of our professors back to our ESNT all days, and to enjoy coming of these all days again with our whole professors, Professor Hani Hafiz, Professor Tariq El-Baz, Professor Faisal Shaheen, Professor Riyad Al-Saeed, Professor Saeed Khamis, Professor Ahmed Halawa. You are so lucky. Our first lady today is really the first lady, which is Professor Maria Hasaballah. She is the moderator of this meeting. She is the Egyptian Society of Nephrology Transplantation President now, and she is Professor of Nephrology in Cairo University. She is the General Secretary of Middle East Society of Organ Transplantation. And the second lady is Professor Mona Roshdi, Professor of Nephrology. So not to disturb this piece of art picture, I will go back to my audience chair and leave this meeting to Professor May to drive. Please, Professor May, start and introduce Professor Mona and our topic today. Thank you.
Thank you very much.
I hope you enjoy this.
Thank you, Yasser, for this introduction. Thank you very much. And thank you for choosing this subject, which is really a very important subject that we come across all the time with our patients. And we are lucky today to have Professor Mona Roshdi. She is one of the very distinguished professors in Qasr Al Aini and all over, actually. And she will be talking to us about perioperative management of patients with kidney disease. Please, Mona, go ahead. Of course, I'd like to welcome all my friends and colleagues here. I'm very happy to have you all with us in this session. Thank you very much.
Thank you very much, Professor Dr. May, for your introduction. Thank you very much, Dr. Yasser. Is my screen shared now? Are you able to see it?
We can see clearly.
Okay.
But you can please make it full screen.
Full screen.
Okay.
Yes. Okay.
Now it's clear.
Yes. It's
okay. My presentation today. Thank you very much for all of my professors, my dear professors, for attending today. I hope it will be a fruitful meeting. My presentation today is about the perioperative management of patients with kidney disease. I try to next to move it. Okay. I will try to cover the following points: the surgical morbidity and mortality in CKD patients, surgical risk calculations in CKD patients, how to evaluate CKD patients preoperatively, and how to assess the risk. What are the important steps in the intraoperative management of CKD, and what are the important considerations for the post-operative management in CKD patients. Then I will try to sum up all the previous points in a clinical vignette and summarize the perioperative management. At the second part of the presentation will be about highlighting specific points in the perioperative management of renal transplant recipients, specifically 2 points: the fluid management and the cardiovascular risk assessment. Elective surgeries can range from minor low-risk procedures, such as cataract surgery, to high-risk cardiovascular operations, such as coronary artery bypass grafting. Elective surgeries are the planned surgery. In contrast to emergency surgery, my presentation today will focus on the elective surgery because it is the one which is liable to preparations and management. People with CKD grade 5 have incident rates of major surgery up to 13 times higher than people with normal kidney functions and higher risks of post-operative complications, including mortality. People with CKD grade 5 often have concurrent chronic health conditions, many of which may be associated with the cause or consequences of their kidney disease. These co-occurring conditions can present a significant additional management burden. Patients treated with dialysis have increased mortality and higher risk for perioperative complications than those not receiving dialysis. Even patients with earlier stages of chronic kidney disease are at increased risk of post-operative cardiac events and mortality. These slides show the different surgical morbidity data in patients with CKD. Okay, can you hear me now?
Yes, yes, we can hear.
Okay, here we see when we observe this slide that dialysis patients here have 8.3% mortality compared to 3.8% in non-CKD patients. Also in complications, here there are incidence of 9% to 11.8% in the major cardiac events or AKI on top of CKD, and this is different in different surgeries. For example, in cardiac surgery, different than in orthopedic surgery, as we see here in the next slide. Here there is increased incidence of soft tissue infections, for example. And so we see that it differs according to the type of surgery and according to the stage of CKD. Dialysis patients are at increased risk, are more increased risk. There are several surgical risk calculators which are developed. This is one of them, which is the National Surgery Quality Improvement Program calculator, which involves many points, many aspects, and one of them is the presence of dialysis, acute kidney failure, and many points in order to calculate the risk for the morbidity risk in CKD patients. I will apply this in my clinical vignette later in my presentation. So this slide summarizes the main systemic complications of end-stage renal disease, which are cardiovascular dysfunction, electrolyte and metabolic disorders, coagulopathy, disturbance of equilibrium, pharmacological issues, and renal anemia. Regarding the cardiovascular disease, it is present in approximately 31 to 50% of people with CKD grade 5, and it is the leading cause of death in patients who receive dialysis. Rates of cardiovascular death are 10 to 20 times higher than in people with normal kidney function. These are the cardiovascular conditions which are prevalent in hemodialysis patients. You can see the arrows, the main or the most prevalent cardiac conditions as the atherosclerotic coronary artery disease present in 42%, congestive heart failure 40%, and peripheral artery disease 37%. Other cardiovascular conditions are valvular heart disease, cerebrovascular, and venous thromboembolism and pulmonary embolism. Pulmonary hypertension is also very important. It's prevalent in patients with CKD ranging from 10% to 25%, stage 5 to 8%, and 68% among maintenance dialysis patients. Pulmonary hypertension is associated with significantly increased risk for death and cardiovascular events in patients with CKD regardless of their dialysis dependence. Pulmonary hypertension is associated with increased perioperative mortality and morbidity, including hemodynamic instability, hypoxia, and respiratory failure. To be evaluated preoperatively is the risk of acute kidney injury. It is common complication and it is different also in occurrence, ranging from 10% after orthopedic procedures up to 28% following cardiovascular surgeries. We have to assess the baseline kidney functions using the eGFR within 1 month of surgery and consider the use of risk prediction tools. There are several risk prediction tools evaluating the risk for kidney injury postoperatively. Most prevalent or most used are the Cleveland Clinic Foundation Risk Score and the Society of Thoracic Surgeon Risk Model. The main points to be addressed, or the main risk factors which are present in these calculators, are the presence of diabetes, the hemodynamic instability, and the cardiac surgery characteristic. In assessment of the cardiopulmonary risk, the American College of Cardiology and American Heart Association identify the clinical risk for major cardiac events in the general population as the presence of unstable coronary syndrome, decompensated heart failure, significant anemia, and severe valvular heart disease. So the risk markers for coronary artery disease include ischemic heart disease, compensated prior heart failure, diabetes, renal insufficiency, and cerebrovascular disease. So the cardiopulmonary risk assessment it is suggested to do a baseline electrocardiogram and Doppler echocardiogram, then to assess the functional capacity using the MET criteria. For maintenance dialysis patients, consider non-invasive cardiac testing as dobutamine stress echocardiography. If considered high or risk or non-invasive testing is not adequate, consult cardiology expert. This is regarding the dialysis patients. Dialysis patients are at high risk, so there is a recommendation to perform stress imaging, non-invasive stress imaging in dialysis patients. So to sum up again, if the patient has a clear history of a cardiovascular disease as ischemic heart disease or prior heart failure, or all the factors I mentioned, my primary cardiac infarction or major cardiac event, then he is considered a cardiovascular patient. So he is referred to cardiologist to perform the cardiovascular, for example, treatment and vascularization if the patient has ischemic heart disease or myocardial infarction. If there is no risk factor is identified, then the risk stratification should be performed by estimating the metabolic equivalence, or the METs. Here, this is the table. This table shows that one MET means that the patient is able to self-care, to dressing, to walking indoors, to walking 1 block on level ground at 2 to 3 meal per hour. 4 MET if he is able to climb a flight of stairs, walking on a hill, up a hill, walking on a level ground 4, golfing, dancing, running a short distance. More than 10 is able to do a strenuous sport, for example, baseball or football. If functional capacity is more than 4 METs, no further testing is recommended. If unknown or less than 4 MET, it is considered intermediate indeterminate cardiac risk. So he should perform a non-invasive cardiac stress test, for example, dobutamine test, for example. 1 MET is defined as the basal oxygen consumption of a 40-year-old 70-kilogram man. This also applies to the CKD patients. There is another cardiac assessment in patients with transplantation. I will highlight it in the second part of the lecture. Regarding hypertension management, it is associated with increased risk for adverse outcomes in perioperative settings, including AKI, cardiovascular outcomes, and CKD progression and loss of residual kidney function. Adequate blood pressure control and volume control is recommended. The American College of Cardiology and American Heart Association 2017 hypertension guidelines set a blood pressure goal of less than 130/80 for patients with CKD and others at elevated cardiovascular risk. Moreover, other guidelines recommended pre-dialysis and post-dialysis blood pressure goals of 140/90 or 130/80 millimeter mercury. The blood pressure target that optimizes outcomes in hemodialysis patients is also unknown. Observational studies consistently show poorer survival with pre-dialysis blood pressure less than 140/90. It is stated that patients when the blood pressure is above 180, below 180/110, the patient is unable to or is not eligible for operation. I mean, it is uncontrolled. This blood pressure is considered uncontrolled, and he is not eligible to perform anesthesia or operation. The degree of hypertension that's considered safe for an elective surgery is, as I mentioned, to the target, but never above 180/10. This is according to the references. Blood pressure lability is in surgical setting is a problem. During anesthesia, blood pressure lability may occur. What about the ACE inhibitors? There is no clear guideline to stop the ACE inhibitor because of hemodynamic instability, but it is left there's a decision for the nephrologist if it is associated for hyperkalemia, for example, or if the patient is anticipated to blood loss or volume loss. So it is reasonable to stop the ACE inhibitor. Otherwise, surgery may be deferred or delayed for individuals with severely uncontrolled hypertension if there is evidence of end organ damage, electrocardiogram changes, or concerning for ischemia or CKD. The presence of hypertension can also influence the response to anesthesia. Then I will shift to the next point, which is the anemia management and the bleeding risk. Patients with advanced CKD or who are receiving maintenance dialysis are increased risk for perioperative bleeding. Perioperative bleeding contributes to both mortality and morbidity, including the need for blood transfusion and reoperations. Optimization of anemia preoperatively with the use of recombinant human erythropoietin and treatment of iron deficiency anemia may minimize the risk for post-operative transfusions. The use of erythropoiesis stimulating agents can also help to reduce the bleeding time and enhance the platelet aggregation independent of anemia treatment. It is essential that patients receiving maintenance dialysis are dialyzed adequately before surgery. It has been shown that adequate dialysis improves functional platelet abnormalities. The dialysis adequacy here in this respect is KT overview 1.2. It is unknown whether increasing preoperative dialysis that dose reduces the bleeding events or improves surgical outcomes. There are many patients who are on treatment with either warfarin or dabigatran or factor 10 inhibitor. These patients are advised to hold the treatment. Regarding warfarin, it is hold 3 to 5 days before surgery, and we have to check the INR 24-hour preoperatively. Dabigatran is 2 to 4 days if the GFR is 30 to 60. GFR below 30, we have to stop 3 to 5 days, and it is not recommended in patients on maintenance dialysis. Regarding factor 10, it is stopped 24 to 48 hours and 36 to 72 hours less than 30. And all direct oral anticoagulants should be avoided in use in patients taking spinal or epidural anesthesia because they have a risk of bleeding. The surgical team is advised to do all the efforts to reduce the risk for symptomatic post-operative bleeding, for example, selection of surgical approach, placement of drains, and more vigilant post-operative monitoring. According to the 2012 KDIGO practice guidelines, indications for blood transfusions are acute severe hemorrhage, unstable coronary artery disease, and the need for rapid preoperative hemoglobin correction, hemoglobinopathies, bone marrow failure, and ESA resistance. We have to confirm that the blood transfusion should be given in minimal situation or to be avoided as much as possible because it exposes the patient to sensitization, especially if he is a future transplant recipient. However, some indications are present there in acute conditions, for example, in rapid acute hemorrhage without immediate control of bleeding, when the estimated blood loss is more than 30 to 40% of blood volume with symptoms of severe blood loss, or if the symptom of the estimated blood loss is more than 25 to 30%, but there are signs of hypovolemia which recur instead of colloid and crystalloid resuscitation. In patients with comorbid factors, transfusion may be necessary to with lesser degree of blood loss. Regarding patients with acute coronary syndrome, there is a risk of cardiovascular mortality and non-fatal myocardial infarction if recurrent ischemia at 30 days was significantly higher in patients with hemoglobin concentration below 11, and correction of anemia. This is regarding acute coronary syndrome. Regarding heart failure, there is no specific guidance of red cell transfusion to treat heart failure, and general indication for red cell transfusion apply to patients with heart failure. However, careful attention must be paid to volume status. There are some criteria proposed for preoperative transfusion. they are not recommended if the hemoglobin is more than 10. However, they can be given with the hemoglobin less than 7. When the patient is otherwise stable, 2 units of red cells should be transfused, and the patient's clinical status and circulating hemoglobin should be reassessed. High-risk patients are more than 65 years, or those with cardiovascular respiratory disease may tolerate anemia and may be transfused when the hemoglobin concentration is less than 8. I confirm that once more that the blood transfusion exposes the patient to sensitization, and it should be this should be also discussed with the patient. Additional risk assessment in the dialysis population there are maintenance diets may influence adverse outcome, including infectious complications and malnutrition, as malnutrition and infections may put some hazard and complication to the wound, for example, as delayed wound healing and wound infection, and patient with numerous risk factors may are more prone to infections. Preoperative dialysis. Heparin is used as the first choice for anticoagulant for hemodialysis because the heparin effect lasts 4 hours. Elective surgery should be scheduled at least 6 hours after dialysis to avoid perioperative bleeding. If heparin is used during hemodialysis, heparin-free dialysis is excluded in this recommendation. And I mean, if the patient performed the heparin-free dialysis, so he can perform the elective surgery less than 4 hours. Regarding the intraoperative management, there are general aspects in the intraoperative management, as the intravenous access and blood pressure monitoring should avoid the AV fistula arm. Patient identification armbands must not encroach on the fistula, and compression of the fistula during surgery must not occur. It has been recommended that subclavian central venous access should be avoided. Now I proceed to a very important topic, which is the perioperative fluid therapy. The fluid therapy is very important topic in both CKD patient and transplantation. I will concentrate now on the CKD patient, non-transplant CKD patients. So what is the best intravenous solution for fluid therapy in patients with end-stage renal disease? First, if we compare the colloids and crystalloid, there is no beneficial effect of colloid on survival in critically ill patient. Furthermore, hydroxyethyl starch is associated with high risk of developing acute renal insufficiency and is not used. This is guidance grade A. What is as for cholesterol, studies have demonstrated that hyperchloremia secondary to the use of 0.9% saline was associated with poor post-operative outcomes in non-cardiac surgery. On the other hand, the use of balanced solution was associated with better kidney function and a better 24-hour survival rate. In clinical trials, the use of balanced solution was associated with better control of the plasma acid and electrolyte balances. Balanced solution, we have to know that they have a potassium, and so there is a potential of increased potassium, increased levels of potassium. However, I will show you in the transplantation group data studies with saline, with normal saline, which was associated with elevation of serum potassium post-operatively. There is anyway, the type of fluids should be selected carefully on the basis of the patient's perioperative status, including volume, electrolyte status, and hemodynamics. Evaluating the intravascular volume status based on CVP or pulmonary artery wedge pressure is of limited use, however, because of the measures are poorly related to the patient's fluid responsiveness. Insertion of pulmonary artery catheter, which is invasive, doesn't improve the outcome in critically ill patients. Pulmonary artery catheters are not recommended. Now, all the critical care studies and journals are recommending the goal-directed therapy based on the dynamic monitoring of systolic pressure variation and pulse pressure variation and stroke volume variation, which according to the study, improved outcome in high-risk patient compared with the standard management protocol. So this was a review article explaining the prediction of fluid responsiveness according to the fluid load, comparing the systolic volume variation. And here, as you see from this graph, there is the systolic volume variation is simply the difference between the minimal systolic volume and the maximum systolic volume. And so it depends on the preload. And dynamic test where they can detect if this volume of fluid leads to increased systolic volume or not, instead of depending on, for example, CVP or static measurements, which are not indicative of the real fluid status of the patient. And so the patient is liable to fluid overload, which is harmful as equal to the fluid underfilling, as both lead to hazards to the patient and side effects of the patient. And according to the critical care journals, they often state that we have to consider fluid as a drug. It is not harmless. If you give the patient plenty of fluid, and you will expose him to overload and pulmonary congestion, for example, it is as hazardous as underfilling and hypovolemia. So this table is very nice. It summarizes all the recommendations. For if we start here, I will start with the values with grade A, which we are sure of. Here, grade A is central venous pressure from below upwards. Central venous pressure is not a useful endpoint for administration, for fluid administration. We see here that this is based on non-kidney transplant systemic review of 24 hours, 24 studies assessing CVP as a monitor for volume status, found that they are not useful as an endpoint for fluid administration. The use of starch above, it is not recommended. The recommendation is against the use of starch, grade E. Balanced crystallized solution are at least equal or even not, if not better. They are preferred than the saline. And it is probably no benefit for routine use for albumin. It is not very clear. Albumin administration is not very clear, and this I will highlight this more in the transplantation group. General large volume of administration or high CVP is not recommended. This is again I will highlight it. It was the trend in the 90s to give plenty of fluids and to elevate the CVP, but this is grade C. Okay. If we shift to another point, the regional and the neuroaxial anesthesia, there are plenty of recommendations regarding the anesthetic material, but I didn't go into the details with it. I only want to highlight that local anesthetic may be delayed and the duration may be lower because of the low protein binding, and we have to confirm the platelet number and function to be before any regional technique, as I mentioned before. Regarding the post-operative consideration, the fluid status, electrolyte, urea, creatinine levels facilitate decisions regarding the solution type or dose and need for urgent post-operative dialysis, determined by the pre-operative hydration status of the patient, duration of surgery, and estimated fluid losses occurring during surgery, along with dynamic preload measures if utilized. As with intraoperative fluid, usually a low background maintenance fluid infusion, taking into account native urine output and insensible losses, supplemented by bolus doses of crystalloid or colloid to maintain hemodynamic stability and help to reduce the likelihood of fluid overload. Overzealous administration of intravenous fluid risks tissue and pulmonary edema, as I mentioned, especially that the patients are usually having diastolic dysfunction, and under administration risk hemodynamic instability and impairment of oxygen delivery. Hemodialysis after the operation is ideally delayed until the risk of fluid shifts and hemorrhage has fallen. Some suggest at least 24 hours post-operatively. Anticoagulation may be needed to be reduced or omitted. Regular hemodialysis should be continued on a routine schedule of 3 times per week. Anticoagulation is heparin. Injections should be used, resumed 12 hours after surgery until stable homeostasis to reduce the risk of bleeding. There are specific pharmacological issues and drug choices to be taken into account. First, the post-operative analgesia. The patient suffers usually from chronic pain. He will have a higher analgesic requirement and should receive her usual analgesic supplemented by additional methods, for example, regional technique to cover from acute surgical insult. Usually, the anesthetics use wound infiltration or nerve block and regular paracetamol. It should be used regular and can be given as an IV method. significant to aim of the paracetamol regularly is to decrease the risk, diminish the opioid requirements in order not to need opioid requirements to be very high. The use of intrathecal or single shot epidural opioids can give analgesia up to 24 hours, but the experience with the end-stage renal disease population is limited. We have to monitor the patient, as I have written this in bold, the respiratory depression. It is very important to monitor respiratory depression in the patient. When we know the following information, that the opioid analgesics, some of them have, or many of them has renal excretion, and they have to be reduced in dose. For example, when you see here's the morphine, for example, we have to reduce the dose. Tramadol, there is a risk of lower seizure threshold and altered mental status. There are some safer options as fentanyl. It is safe here as the second one, and codeine. It's better to be avoided as it may lead to serious adverse effects. Then in the post-operative care, we follow up the electrolytes, urea, creatinine, and checked and as indicated thereafter. Then now I tackle the most important points. I will try to apply it on a clinical vignette. This clinical vignette was, I quoted it from the American Journal of Kidney Disease from an article. I put it as a reference at the end. A 56-year-old man with diabetes mellitus type 2, for which he used insulin, hypertension, dyslipidemia, and kidney failure, treated by maintenance hemodialysis, is referred to an orthopedic surgeon for persistent left hip pain. Tricompartmental osteoarthritis of the left knee was diagnosed 10 years ago. Unable to use non-steroidal anti-inflammatory drug, always the nephrologist advising not to use non-steroidal inflammatory drugs. So he has been using only topical analgesic without relief. He became more sedentary and he is in pain. The orthopedic surgery recommends a total knee arthroplasty. Before deciding, the patient wishes to discuss the surgery with his nephrologist. So he goes to the nephrologist. First thing the nephrologist will do is to use this surgical risk calculator in order to calculate the risk for, as I typed total knee, then a scroll down menu came down with, then I chose the arthroplasty. I entered all the information, and here at the top of the slide, we can see that the risk factor for this patient is diabetic, hypertensive, dialysis, and then all the complications can be seen here, and the risk of the complications. In the risk calculator, there is also an option to increase, to change the risk. Here, for example, the surgeon adjustment of risk, and here also the predicted length of hospital stay was calculated. And here the surgical adjustment of risk, when this is only the impression of the surgeon that the risk is underestimated, for example. So he will take here the adjustment is necessary. Risk is somewhat higher, and so it changed the risk change when the surgeon chooses the risk is higher. Here, for example, there is a discharge to nursing rehabilitation facility, and there is a risk of readmission, and all the risk will change. And the end, the calculator give me the option to email it for me. Because the pain is limiting to his exertion, metabolic capacity cannot be evaluated. Anyway, this patient is diabetic, and on hemodialysis, he has to do a non-invasive testing for coronary heart disease because he is has many risk factors, especially being on dialysis. This is a risk factor, and being diabetic and on insulin, this long-standing duration. So he has to do a non-invasive testing for coronary artery disease, for example, dobutamine stress test. And then, if any abnormality is seen, he should be referred to cardiologist. Before surgery, anemia and hypertension management were optimized. Also the calcium levels and the PTH level should be checked. Assumed that the patient was following up with the nephrologist and has everything controlled. Surgery was scheduled for a midweek non-dialysis day to avoid increased morbidity and mortality from the long dialysis-free interval. So again, if we summarize everything, this is the first part with the chronic kidney disease non-transplant, the cardiovascular dysfunction. We have tailoring of blood pressure risk, cardiac risk assessment, and management. The electrolyte and metabolic disorder, we have to check for hyperkalemia. We have to adequate solution monitoring and fluid monitoring. Regarding coagulopathy, by transfusion very limited, or to give the patient correction of the anemia with ESA, for example, or iron, and the discontinuation of antiplatelet. Disturbance of equilibrium, it is suggested to goal-directed therapy, as I mentioned, regarding systolic volume variation, and regarding pharmacological, appropriate drug choice, especially in analgesic, and correction of anemia and prevention of alloimmunization. Now I will shift to the second part, which is the perioperative management of renal transplant recipient. I will try not to go into details with only stressing on the points which are important before or immediate in the perioperative period. So we have to check the comorbid illness, again, the diabetes and the ischemic heart disease. I depended in my presentation here on two guidelines, the best European guidelines and the KDIGO guidelines for renal transplantation. So this slide is, the reference of this slide is the best European best European guidelines for transplantation. Here, if the patient is more than 50 years, who has a history of cardiovascular disease or diabetes, with normal transthoracic ultrasound and normal minimal exercise testing, he has to do a normal dobutamine. He has to do a non-invasive stress testing again, which is dobutamine or a normal nuclear imaging test. These are the KDIGO guidelines of 2020, and they state that we have to evaluate all candidates for the presence and severity of cardiac disease with history, physical examination, and ECG. Candidates with signs and symptoms of cardiac disease should be referred to cardiologists to undergo management before being considered for transplantation. Candidates at high risk for coronary artery disease with poor functional capacity should undergo non-invasive coronary artery disease screening, and asymptomatic candidates with known coronary artery disease should not be revascularized exclusively to reduce perioperative cardiac events. Patients with asymptomatic advanced triple vessel coronary disease, uncorrectable, and symptomatic New York Heart Association class 3 and 4 should be excluded from transplantation. And asymptomatic candidates who have been on dialysis for at least 2 years and have risk factors for pulmonary hypertension should undergo echocardiography. With estimated pulmonary pressure greater than 45, severe valvular heart or myocardial infarction should be assessed by a cardiologist. Regarding antihypertensive, hypertension is often refractory and impairs autoregulation, and so high doses of ACE inhibitors should be withheld perioperatively, and there is evidence, unless there is evidence of left ventricular dysfunction. Beta blockers, aspirin, statins should not be stopped perioperatively. Regarding peripheral arterial disease, as I mentioned in the very first slides, that the incidence is high with peripheral artery disease. It should be assessed with history and physical examination, and patients also without clinically apparent peripheral artery disease should undergo a non-invasive vascular testing. Diabetes should be managed and treated, and blood glucose level should be controlled. If the patient are not known, glucose tolerance test should be done. Regarding pulmonary disease, chest imaging before transplantation. If the patient is a smoker, CT chest, and pulmonary function testing is important to detect or to confirm the functional capacity of the patient and respiratory symptoms, or if the patient has a history of respiratory disease. Regarding smoking, the patient should abstain from tobacco use at minimum of 1 month prior to waitlisting or living donor transplantation, and he should be counseled to avoid tobacco products. The important topic of colloids and type of crystalloids. Regarding albumin, there is theoretical advantages of albumin, including increased plasma oncotic pressure. It has antioxidant properties, enhanced protein transport, anti-inflammatory properties, and buffering capacity. The crystalloid have the advantage of rapid equilibrium between different compartments and increased risk, but there is increased risk of pulmonary interstitial edema and decreased tissue perfusion. The risks associated with albumin include increased cost, potential disease transmission, immunogenicity, and albumin is was not associated with improved outcomes. Recent available evidence suggests that there is no advantage of albumin over crystalloids, so it can not be used alone. However, the grade is low-level recommendation. transplant recipients during the perioperative period, how about the choice of solution? Is it 0.9% again, or balanced solution? Here, this is also the recommendation of the European Renal Best Practice Guidelines of 2015. Here, they stated that there is no evidence to prefer one type of solution over the other. And in line with the European guidelines, we have to be cautious with the use of starches, as I mentioned before. And we have to monitor very efficiently for metabolic acidosis. However, this is the consensus statement of the fluid management in the American Society of Anesthesiologists, which is 2021, which is a recent reference. I showed you this slide before, but I concentrated on the non-kidney disease, non-kidney transplantation patients. It is almost the same for the kidney transplantation. Here, there is, regarding albumin in kidney transplantation, here we find that there is no benefit in 2 randomized controlled trials, and in kidney transplantation, balanced crystallized solution are associated with the better metabolic profile and equal, if not lower, potassium level. Here I will show you this study which used the normal saline, and it performed a simple linear regression and multiple linear regression analysis to adjust it for the total volume of fluid administered, and it showed that there is a rise of potassium level for each 20% increase in the proportion of normal saline. So it is not, very right that the balanced solution will give rise to increased potassium in comparison to normal saline. It is very important also in the kidney transplant patient, not only the volume status of the patient, but also the graft function. So this study compared the fluid with the graft function. It showed that there is a perioperative normal saline infusion was associated with delayed graft function in deceased donor kidney transplant recipient. Post-operative hyperchloremia and hyperchloremic acidosis were not associated with increased risk, suggesting that other mechanism than a chloride effect may be the cause. I took this picture from the Transplantation journal. It shows that starch has a red warning. It is not allowed. Albumin is only yellow, so it can be used, but it is not very important or not recommended. Balanced crystalloid has a green light associated with less acidosis and less hyperkalemia. Amount of fluid administration. This is important, very important. During the 90s, there was maximum volume infusion for kidney transplantation. There is low quality evidence for a larger volume administration. Targeting a higher CVP during kidney transplantation, and the use of a CVP as a guide to fluid administration is weakly supported. These are all the guidelines of the American consensus statement of the American guidelines of anesthesiologists 2021, and there were no robust data indicating harm with CVP used as a guide if a mean CVP was maintained more than 5 to 8 millimeter mercury without fluid overload. That means that CVP not more than 11 with higher temporary values at the time of reperfusion. Accelerated fluid administration during graft ischemia rather than constant infusion may lead to improved graft function. This study shows that central venous pressure monitoring in liver kidney transplantation does not affect immediate graft function. Here we see the hospital length stay, creatinine reduction ratio on the post-operative day, delayed graft function, and acute rejection. All, if you see the right column, they give non-significant values. Again, the monitoring is better. All the critical care journals and studies are directed towards the stroke volume and the pulse pressure variation and the esophageal Doppler and the plethysmography pulse variability. Although no specific to fluid volume, avoidance of intraoperative hypertension with different thresholds supports the improved graft function. So we have to avoid the hypertension. That is logic. This is a sum up of studies, which is the evidence about monitoring of volume status. Here we see the use of CVP with good perioperative fluid hydration associated with good early graft function. This is the first one, but the second one is no effect, absolute value, no difference. And CVP graft outcome. Arterial blood pressure less than 70 associated with poor, but then the three in the bottom are the systolic volume SVV. They replace CVP and may improve the graft perfusion and critical time. CVV can correctly predict the preload status, and Doppler guided fluid. All are directed towards dynamic fluid guidance. It is not recommended. There is a recommendation again. This is since 2015. There is a recommendation against dopaminergic agents in the early post-operative period. It doesn't improve the graft function survival. There are other variable issues. For example, obesity are not excluded from transplantation, but they are advised to weight loss interventions. In patients with frailty, we have to suggest or to give them preoperative rehabilitation, to encourage them for reoperative rehabilitation, because and all medical conditions that may inhibit the wound healing, for example, obesity or undernutrition or smoking, or any factor which can impair the wound healing, should be managed. Regarding the antiplatelets and the anticoagulants, antiplatelet except aspirin should be stopped 5 days prior to living donor transplantation. And we have not, to transplant patients on direct oral anticoagulants, except when there is specific expertise using perioperatively and access to reversal agents, because they can do considerable bleeding. They have to be stopped, as I mentioned before. Switch to an alternative anticoagulant for warfarin prior to waitlisting or living donor transplantation if recommended by thrombosis or expert hematologist, and or if there is expertise using direct oral anticoagulants perioperatively. Use of non-heparin based agents in patients with heparin-induced thrombocytopenia. Low molecular weight heparin, unfractionated heparin or aspirin before transplantation to prevent graft thrombosis is not recommended. This is from the European European guidelines of 2015. Hemodialysis prior to operation. It is not recommended routinely to perform, but it is especially only if there is specific indication. It is if it is performed, it is not recommended to do an ultrafiltration except if there is evidence of fluid overload. However, it may lead to the patient to be intravascularly deplete. Although dialysis renders the patient transiently anticoagulant, short half-life heparin obviates the problem perioperatively. Most transplant anesthesists operate by the idiom, if in doubt, dialyze. Finally, the urinary bladder catheter as soon as possible after transplantation, and we recommend monitoring of adverse effect as infection, leakage, or any complication. I put at the end I had many references in my presentation today, many references I use and many studies, but I found 5 studies which have the topic in a review, for example, or are very important for the topic. So I suggested them as further reading, and they contain more details than what I mentioned. The first one is the preoperative risk assessment and management, receiving maintenance dialysis and those early stages of CKD, an article in the American Journal of Kidney Disease 2020, and the fluid and management during transplantation, the consensus of the fluid management of the anesthesiologist, which was published in Transplantation in 2021, and clinical practice guidelines for the evaluation and management, the KDIGO guidelines, and the European best practice guidelines. And finally, there is a very nice article with a preoperative cardiovascular assessment in renal transplant, which is very detailed, and it has also studies in every discussing every type of investigation in the cardiac assessment, and the specificity and sensitivity of this test. Thank you very much for your attendance.
Well, thank you very much. It's really wonderful. Really, it was very informative and very elegant. And you almost touched everything before the operation, during the operation, and after the operation. Thank you very much, and very updated. You highlighted the importance of preoperative assessment, risk assessment, and the importance of control of blood pressure. But mind you that some patients, they become hypertensive while they're going to surgery because of stress or tension, but this can be managed with sedations, maybe. You highlighted the importance of correction of blood pressure and anemia management, and when to transfuse, and what fluids to give during the operation, and what analgesia, and when to withhold anticoagulants. I'm sure there will be many questions that will need to be answered by the audience. So let's see if we have any questions. Professor Yasser? Any questions?
Sorry,
Halawa.
yes, sorry, I was muted.
Okay.
I have one question in the chat. Stopping ACE inhibitors, would it depend on the type of operation or making angiography procedure, for example, or we should stop or know the clear data? What's your opinion, Professor Mona?
The ACE inhibitor?
Yes.
Yes, I mean, if the patient, if there is a risk for the patient of, for example, volume loss or dehydration, and also if there is a risk of hyperkalemia. So there is not no clear statement about ACE inhibitor, but it is left always for the judgment of the nephrologist. If he has the impression that it will lead to more hemodynamic instability or he will pose more complication to the patient, so he has to stop them. And we can, to avoid the rise of blood pressure, he can substitute them by any other antihypertensive.
Okay. So no clear, we are left to a judge of nephrologist. The special major risk is hyperkalemia, even if we are going to do angiography intraoperative.
Yes, Dr. Ahmed Halawa would like to comment, please.
Yes.
Actually, we cancel any operation for a patient who hasn't omitted ACE inhibitor.
Omitted?
Yes.
Who hasn't omitted ACE inhibitor? So
we should stop, and this is our practice here in Sheffield and in many UK centers. So any, ACE inhibitor should be stopped 24 hours before the operation, because the problem with ACE inhibitor is it interacts with anesthetics. And to the extent that if the patient has forgotten inhibitor, his operation will be.
Okay, but you think it is safer, and anyway, it is recommended to stop them. Okay.
Yeah. I mean, it's a practice, and I questioned the anesthetist many times. One of them actually put the patient to sleep while he's storing an ACE inhibitor. But the vast majority of our anesthetists, because according to our protocol, they cancel the operation if the patient hasn't omitted ACE inhibitor 24 hours before the operation.
Yes, I mentioned in renal transplantation, they have to be stopped. Yes, in renal transplantation, I stated that they have to be stopped. But I think we were talking about the non-transplantation. But you think about any operation,
Yeah, we operate. We do operation, gallbladder operation, thyroid.
Yes. Any operation.
Hernia, any operation on CKD patients.
Okay.
I think this makes sense, because you really don't know what will happen if the patient continues, if he loses blood or goes into some problems during the surgery. And I believe that stopping them for a while is no big deal.
Yes.
Yeah, just 24 hours. And then we can start, next dose after the operation.
This is the question: when to start again? When to restart again in a kidney patient? Reintroduce ACE inhibitors after suffering this stress regarding hypothermia.
When the patient is stabilized, when he is stabilized and your Tamminti is fine, his blood pressure is picturized, then you can restart.
Yeah, and we have to remember when we deal with surgical patient, CKD patient, minor operation, major operation, minor operation hernias, major operation gallbladders, colectomies, and stuff like that. So both are different. We can, be flexible with the cardiac conditions if the minor operation, because still we can do it under local anesthetics, regional anesthetics, spinal anesthetics. And actually, most of our anesthetists prefer local, regional, spinal on CKD patients. If we come to a major operation where it dictates a laparotomy, in this case, we definitely will stop the ACE inhibitor. Also, in terms of dialysis, because any operation, especially muscle cutting operation, entails hyperkalemia immediately after transplantation, after the operation.
Yes.
We dialyze the patient heparin-free before the operation. We monitor his potassium post-op. We dialyze him heparin-free if he needs to.
Yes.
Another thing, actually, I would like to comment, if you, Professor May, if you allow me, we use fractionated heparin rather than unfractionated heparin. And actually, we don't omit it because the renal Peri patient will have half the dose. We don't omit it for minor operation. We omit it for major operation. However, all the evidence showed that even if you didn't omit it, there's no increased risk of bleeding. But for me as a surgeon, I don't like to test the theory. I stop it because the consequences is bleeding, and I'm the one who's going to stuck with it. So
Yes.
I omit it, for major operation, including transplantation. I start, the night after. And it depends as well whether the operation was straightforward, complicated, any vascular problems, any issues related with the anastomosis, patient is oozing. So again, is reconsidered according to the surgical procedure itself.
Sure. And what about the aspirin, Professor Hamid?
I was about to say it. We don't worry about single antiplatelet, but if they are double antiplatelet like aspirin, clopidogrel, this is no. Because actually, clopidogrel takes weeks and weeks to clear because it inhibits ATP, and subsequently, it takes a while for the platelet to regenerate it. So basically, we stop both. If the patient already on aspirin and clopidogrel, we need to know why. Is he because of has a stent, cardiac stent? In this case, we'll wait for 9 months after, because usually for the coronary stenting, they keep the patient on
dual
antiplatelets for 9 months to a year. If the operation is urgent, so consent the patient for bleeding, and be aware that we'll spend the whole night sorting out his bleeding. But if it is not urgent, we defer the operation till he stops aspirin and clopidogrel. We know if there's something else like history of stroke or in a cardiac event in the past, we'll discuss with the cardiologist and ask him to write in the notes that we can stop. But aspirin, dual antiplatelet, is associated with high risk of bleeding. But aspirin is not, there is, of course, there is small risk, but manageable.
Professor.
Yeah.
Professor Gamal Saadi wants to comment.
I would like to emphasize that the situation for the ARBs is different than that of ACE inhibitors. Would you agree with me, Professor Halawa, that the situation with ARBs is different and we can maintain the use of ARBs in the perioperative period?
Actually, they stop both of them because the patient instruction is very clear. We have what's called preoperative assessment, where they see the anesthetist in the clinic, and they give them clear instruction to stop any sort of ACE inhibitor related or ARBs. So both are the same, treated the same in our place. I would like to comment, and it was like the colloids, yes. Well, I think that Professor Kamal Al-Kasha mentioned last time colloids of no use, and one before when I discussed colloids in transplantation, expensive, hazardous, or no need to use them. Balanced crystalloid is much better. Balanced crystalloid compared to normal saline is much better. And our studies show that, yes, normal saline is associated with hyperkalemia, hyperchloremic acidosis, and of course, But it didn't, in transplantation, it didn't affect graft survival. It didn't affect the incidence of DGF. So it's, you know, biochemical mainly.
So I think that we have these conclusions from our previous 3 sessions in critical care and in transplantation, and this session that no more place for colloids over crystalloids, and balanced solutions are better. Despite that, the evidence in this session looks to be lower than previous 2 sessions of transplantation and critical care. But however, I think it gets the same, that balanced solution are better than normal saline, and no place for colloids. Yes. Do you agree with me, Professor Mike, Professor Mona, Professor
Sure.
Halawa?
Yes, sure.
I think
Yes.
Mona was clear about that, about it. That's what she
Yes.
mentioned. Exactly.
Yes.
Actually, because Professor Marwa didn't attend the last 2, and we mentioned the same thing.
Yes, yes. You were just in the same line, Mona.
Professor
wanted
Said?
to-
Professor Hani, okay, go ahead.
I wanted to ask Dr. Mona regarding the metabolic capacity, because you know most of our dialysis patients are crippled by uremic osteodystrophies, and it is very difficult for them to evaluate their fitness by this metabolic capacity score.
Yes.
So is there any other way to know their fitness without putting them, for example, on a treadmill, or this is from a practical point of view? And also another question regarding the substitute for the CVP, because you know, after transplantation, most of us, we still use the CVP as a one of the marker, not alone, but one of the markers of, to give fluids. So you are mentioning that the CVP is no more put in the guidelines, but what will be the clinical substitute for this?
Regarding the metabolic, the MET criteria, if the MET criteria cannot be assessed, so the patient would be considered to be indeterminate risk for the cardiac disease. So he has to do a non-invasive stress test, and there is no substitution for it. And if he if he can't perform it, regarding the CVP, yes, because it is not a guide. It is not يعني مش مؤشر أو it doesn't show us the real volume status of the patient. So it is better to use a dynamic one. So the dynamic one, as I mentioned several examples as SVV, for example, this is the systolic volume variability between when we give him a preload. This is a more measure for the if the patient is in real need of fluids or not. There are several dynamic tests, I mean, and these are now better to be assessed. They are assessed by non-invasive methods with monitors, and they can be a more guide for us as a fluid management. I want they are
but is it used in practice, for example, in UK, for example, or in other places?
Dr. Ahmed Halawa, if they are still using CVP, or they are
this is my question, really.
Yes.
No, Dr. Ahmed Halawa is against CVP. Please unmute yourself.
Basically, we banned CVP 7-8 years ago, and we didn't use it. Neither intraoperatively nor post-operatively, not only in our unit, but in most of UK units, CVP is dead. Because, you know, intraoperatively, the situation of the patient, you don't know what's a baseline, because, you know, if they said the normal from 4 to 11, no, it's not from 4 to 11. Normal could be -1, -2, -3, and this is considered be normal. So what's normal could be abnormal for somebody else. Number one. Number two, we don't know the fluid status of the patient, because CKD patient, if they are hemodialysis patient, most likely on the dry side, but some of them are overloaded. And the overload, you know, volume overload for CKD patient, He could be edematous, but still intravascularly depleted.
Mm.
We don't know actually the fluid status. It is a very complicated, complex disease and disturbing the fluid balance. So we don't know what's normal for them. Number three, intraoperatively, you open the abdomen, both hands retract to patient's position, ventilation. All this will disturb what you think is normal CVP and packs. So you can't tell that, you can't gauge the fluid balance based on the reading you get as CVP. Post-operatively, we found that the best way is clinically, in addition to weigh the patient. The scale will tell us, how much fluid being added to this patient. So if overnight weight went by 5 kilos, can't be flesh, it's fluid. And also clinical examination, jugular venous pressure, pulse, blood pressure, and input, output, all these calculations. Sometimes we try to make it easy by looking at one reading to summarize the whole picture. It will never be summarized by one method. So we take all together. Also, post-operatively, we tend to ignore what happened intraoperatively. We don't look at the anesthetic chart where the patient had 5 liters of fluid. He lost 2 liters of blood, though this should be counted as well to give you the full picture. There is, monitoring fluid balance is an imperfect science. We don't know, we try hard, but definitely CVP is not the right way forward based on many meta-analysis and randomized trials done before. And the first one done by Merrick and published in Chest in 2005, and then done another meta-analysis, I think 2013, which is very clear that CVP is misleading.
Thank you, Professor Khan. Professor May, Professor Riyad wants to comment. Professor Riyad
Yes,
Saeed.
please, Professor Riyad.
Well, thank you very much for this nice talk. Really, I have one comment about withdrawal of ACE-ARBs. I don't think that really this is what we are practicing, most of the nephrologists. What we are worried about, there is very little really to worry about. My main worry, if you stop that medication, next morning the anesthesiologist will tell you, well, hey, doctor, your patient blood pressure is quite high and I'd like to cancel the surgery. He's going to cancel the surgery because the blood pressure is not controlled. Which is better really, cancel surgery or keep the medication? To me, I'll keep the medication. With due respect to Dr. Halawa, thoughts about what they are doing in UK. That's one thing. Concerning dialysis preoperatively for any patient that we have, there is nothing wrong really with using heparin if there is no major contraindication for it. And that's what we use. If you are worried about long-acting fractionated versus unfractionated, we use really the unfractionated heparin, short duration of time, by 6 hours will be off, and then your patient can continue his regular surgery after that. Thank you. These are the 2 comments that I have.
Thank you, Professor Riyad. Professor May,
Professor Halawa, yes, please. I was just asking Professor Halawa, have you seen patients stopping their ACE or ARBs and having hypertension? Do you come across that often, Professor Halawa?
Please unmute yourself,
Unmute yourself.
Unmute yourself, Professor Halawa.
Okay, the answer is no. We haven't seen it. We are general surgeon operating on renal failure patients, whether transplant them or other surgical procedures, day and night, and we stopped them for 24 hours. We couldn't find any harm. On the contrary, if the anesthetist find that the patient had his ACE inhibitor or ARB in the morning before the operation, it gets cancelled.
I don't know whether this sound practice or not. I don't know how many other people in UK or United States, they do the same thing, but this is special view of our consultant in UK.
Yeah, okay.
What you are doing in Egypt?
I think it's left to the nephrologist to decide, I believe.
Yes, it was not our usual practice. Professor Tariq Elbaz wants to comment. Professor May?
Yes,
Tfaddal, Dr.
yes. Thank you very much, Professor Mona, for. I can't say that this is a comprehensive talk at all. You covered lots and lots of aspects. I beg to disagree with Professor Halawa. I think he's still around regarding the central venous pressure. Excuse me, I just have a point.
Sure.
You say it's a practice now where you are working and elsewhere in the UK not to depend on the central pressure and rather depend on clinical assessment. And during your comment, you mentioned to look at the jugular pulse or the jugular vessels, and this is also assessed by the central pressure. This is what the CVP is about. That's a point. Outweighing the patient, I cannot disagree with you at all. But not all countries have beds fit for that. I understand that there are beds fixed with scales so the patient can be easily weighed. Let's be practical now. If you are working in a particular setting, just as we are here, I have never seen this scales in most of the hospitals that I have visited or worked in. And so many times in the immediate operative few days that are really critical for fluid balance, it's impossible to have the patient weighed by making him stand on a scale, particularly if he has a hip surgery, for example. I still feel that assessing the central venous pressure is something very important, particularly if he has a good heart. He doesn't have a dilated right side. So what's the problem? What's the problem about that? I understand very much and appreciate your comment about what is normal. Is it 4 to 11, as you mentioned, when a minus could be normal for someone? But if we're going to just depend on the clinical assessments and weighing patients, I'm sure we don't have this facility here. If anybody likes to comment from my colleagues who are working in Egypt about this thing.
Yes,
Okay.
I believe I would agree with you, Dr. Tariq, that still the CVP is having an important role in our perioperative management of the patients, and we can still depend upon it. And if we are going to wait until weight changes occur, particularly in transplant cases, this might be a bit late in the management, and we would enter into a period of fluid deficiency before detecting weight changes. So I believe it is still in practice, and it's our everyday practice in Egypt and probably in other parts of the world.
I think, Professor Gamal, it could be misleading. That's the point. And they're not using it, but they're using, instead of it, the dynamic tests. So we don't do that. So that's why we're still depending on the CVP. But actually, it could be misleading, definitely.
Yeah, it might be misleading, but it's an important tool to keep depending upon together with other parameters. But we should not disregard it completely.
Not alone. Yeah.
This was my debate with Professor Halawa in the session in critical care settings, IV fluids, that CVP is our tool, our possible tool that we can use bedside to judge or the patient. And we can say that if there's conflict between the CVP and a clinical assessment, so please don't depend on the CVP. But if both are going, as the classical example Professor Tariq Elbaz said, I think why not to use? It is a possible tool and it's easy to use bedside. This was a matter of debate in Professor Kamal's session with Professor Halawa. I know he is. You want to comment, Professor Halawa, more, or you are against
No, it's all right.
the way?
The way.
By the way, it's not Professor Halawa. This is the consensus. that
Yes,
Mona has
I
been-
see. The difference here, we want to use our all possible clinical tools,
Yeah.
and not to stick to academic lessons.
I mean, we
well-
are in an era of evidence-based medicine. So
Yes.
we rely mainly on evidence. And evidence, basically, we have hierarchy of evidence, level 1, level 2, level 3, level 4, level 5. So if I said my practice, this is level 5.
Yes.
Lower. If I said based on systematic review meta-analysis, this is level 1. And level 1,
Yes.
1A and B, and 2A and B, and the same.
Totally agree with you.
Yeah. So basically, it's all about my feeling is all about the evidence. So evidence, demonstrated clearly. However, it was not level 1; it was level 2 that demonstrated clearly the CVP is misleading, and if even the principle of the CVP was wrong, the principle of CVP that the pressure in the right side of the heart indicates the pressure in the left side of the heart even is wrong, not based on evidence. So the principle itself was not based on strong evidence. So basically, if you are fine, if you are not relying entirely on a CVP, you're relying on this, you take the CVP into account, into consideration, in addition to the other parameters like the fluid loss, fluid input, the perioperative fluid patient received, intraoperative fluid patient lost, all this, together, you make a judgment. Regarding the weight, you don't need a bed with, attached to a scale. Basically, next day morning, you ask the patient to stand up. Actually, next day morning, the patient expected to sit on a chair and walk around the ward. So we'll be moving out of bed next day morning. And this is when we weigh him. Once he's out of bed, which is next day morning, get weighed. The scale is a cheap scale, 3 pound, so it's not an expensive one. So the scale itself is not an issue. It's available. This is actually normal scale you use at home as well.
Let me ask you directly, Professor Halawa, direct question, getting a yes or no answer, please. The classical simple example of Professor Tariq El-Baza of a simple patient going young man with everything is normal, a normal heart and normal fluid status. If he has a CVP post-operative, should you depend on it, on assessing his intravenous fluid status, or will not depend at all?
I wouldn't use it.
Yeah?
I wouldn't use it.
Would use evidence fixed and the patient is nothing wrong with him, and even serial following of a CVP will not use it
at all.
Or against
this is against the protocol. This is against the guideline. This is against the evidence.
Okay, we have some comments from the floor from Professor Ismail Ibrahim. Professor Ismail Ibrahim says that the point of ASR is inhibitors or ARPs are not that strong antihypertensives to worry about holding them. CVP serial in a very same patient could be of help, and we discussed it a lot. There is another question about the use of intraoperative CRRT. Any data, Professor Mona Roshdi? Intraoperative CRRT. For my knowledge, I think he is asking about the use in case of contrast nephropathy or something like this. No clear data about the superiority of use of CRRT. Even if you have for volume overload or something like this, I think no clear data about the superiority of use of intraoperative CRRT in intra. Professor Faisal Shaheen wants to comment. Professor Mike?
Yes, please, Professor Faisal.
Yes, thank you. I enjoy the talk and the discussion, but I rather maybe I will go with my colleague for Dr. Tariq and others about the CVB. My own practice is to have the CVB, remove it after 24 hours, just only because we have living related mainly, and we have diuresis, post-operative up to 1 to 2 liters per hour. So we have to judge our patient as well. He may go to severe hypovolemia and problem with, again, kidney shutdown. So still I am depending about CVB at least for the first 24 hours. Since the patients have already CVB, because we are giving ATG as a prophylactic, and it's giving through the central line, why I don't utilize it in the first 24 hours. About the ARB and the AC, our practice is to continue, not to stop it.
Okay. Thank you, Professor Faisal.
Thank you. So,
Professor Saeed Khamis.
Thank you, Professor Mona, for this elegant presentation. Just one comment regarding the for Professor Halawa and Professor Mona regarding the pitfall or the malpractice from some anesthetists regarding the over fasting prior or before preoperatively for the high risk patient to develop AKI. My question, what is the optimum time for fasting in such situation? I mean, if it is a major versus minor operation, abdominal versus non-abdominal, spinal anesthesia versus general anesthesia, what is the optimum time, and when can we resume the oral route after or post-op? Thank you so much.
I think there is no specific guidelines for kidney patients. They have the same rules as non-kidney patients, and when to resume the oral feeding depends also on the operation, when it is an abdominal surgery or is it simple with regional anesthesia. I think it's comparable to the non-kidney patients. There is no specific guidelines for them.
And I believe if they have to fast or the operation is postponed or is late, the doctor is late, I think they should be given intravenous fluids during that time until the operation is due.
Yeah.
But how many hours exactly to fast before the operation? Dr. Halawa, do you have an answer to that?
I don't know, Dr. Halawa is still with us or not.
Unmute yourself, Professor.
Yeah, it's 6 hours, and 6 hours, not to drink any fat-containing fluid like milk or meal. We give the patient a carbohydrate drink up to 2 hours before the operation, because the carbohydrate drink is not retained in the stomach. The problem with CKD patient, they have delayed gastric empty. So the standard general surgery patient 4 hours, for CKD patient 6 hours. If the CKD patient is a transplant, of course, transplant is a CKD. Yes, the Professor May will give IV fluid because we need the patient to be well hydrated, but not overhydrated. Resuming fluid intake for transplant patient immediately after the operation, when the patient recovers. In the recovery, will be given a cup of tea and light dinner same night. I'm sure everybody will argue with me now.
I don't think any one of us do that. Does that.
Yeah, there's you are yes. Yeah.
You will not wait for intestinal movements?
No, we don't check it.
Okay.
This is for yourself, Professor Halal, or for all surgeons? I'm sure for some.
Opening the floodgate. Don't check it, because there's a practice when you listen to the to the bowel movement. Actually, you could have silent bowel, but what's important, the absorption from the stomach and upper small bowel still working. So we give him light drink, cup of tea, and see how it goes. Usually well tolerated. And later on, 3 or 4 hours later, because if we transplant the patient in the morning, he will have light dinner at 6, 7 o'clock, very light dinner. And the next day morning, breakfast, light breakfast. Because we'd like to feed him, because this patient is catabolic. So we'd like to get him right and start eating and drinking. Also, when you start eating and drinking, the gastrocolic reflex will work and he will start opening his bowel, because constipation, this is one of the problems. Constipation pain could be a lot worse compared to the operative pain itself. So we'd like to get him out of bed next day morning, eat and drink, and encourage him to eat and drink. Also, in addition to this, we give him laxative as well to make sure that he won't get constipated. So it's all about enhancing his recovery rather than waiting for things. We push things.
So my Professor Tara Elbaz and Professor wants to comment, and
Yes,
Professor
please.
Arifaha also.
Professor Tara.
I'm not going to comment about that one. You are the surgeon. You are the surgeon. Okay, I'm not going to. Just since you were talking about fasting, I have something maybe that you find interesting. I was preparing a talk about xenotherapy in renal transplantation. And I came across this very interesting experiment. Actually, it is an animal experiment on mice. And these mice, before transplantation, they were subjected to fasting for 3 days. Not absolute fasting, fluids were freely given to these mice, but no other foodstuffs at all. And the results were much better than those mice that I'm talking about. The presence of senescent cells, which are quite injurious to the grafts. So the load or the burden of senescent cells has been shown to decrease very much when these mice fasted for 3 days. No one so far, I found it sounds very interesting and seems to be easy, but so far it has not been practiced yet or experimented. Humans. It's just something that you brought up when you are talking about fasting. I just wanted to talk to you about that.
Interesting.
Thank you. We try not to, starve the patients. We try to get them, keep him rehydrated, eat and drink, shortly after the operation when tolerated. If he's sick and vomiting, of course, wouldn't do that. But, the sooner the better to get recovered and get home.
Thank Professor Mona for this nice lecture. Thank and welcome all for this nice discussion. My question, Professor Mona, about how about a patient with for preoperative assessment? He not have any chronic illness, rather than he have a CKD grade 2 or 3, or stage 2 or 3. How about this patient? And the operation is not emergency, but not delayed. Say a cancer patient, we need to the anesthesiology usually postpone the operation until create reach 1.5 or like this. How about we can do? You hear me, Dr. Yasser?
Yes, yes. Yes, I can hear you.
Yeah. Dr. Mona?
I believe it. I heard that I didn't hear very properly, but you mean that the patient is grade 2 or 3 only, and he has to do an operation, and the anesthesia refuses to do the operation?
Yes.
Uh,
يعني مفيش no correctable causes. He is a CKD, maybe a hypertensive or analgesic nephropathy, but he have a cancer for cancer surgery, and mostly refer those patients to us to do the fitness about renal. What we can do, the anesthesiology always refuse to do this operation.
Yes, I mean, if the patient is stable, that means he doesn't have anemia and he doesn't have any hyperkalemia.
Yes.
So there is no problem with the operation.
I think that the anesthesiologist,
we can calculate. I think I would calculate the risk score by the surgical calculators and tell him that by the surgical risk calculator, the risk calculator is a percent. As I calculated it, I would do this, but sometimes I can't get the creatinine back 1.5. Yeah.
That's because those doctors, they do not understand the difference of, they believe that it's in your hands to reduce the creatinine, the serum creatinine. They do not appreciate the difference between acute kidney injury and chronic kidney disease. That's why they tell you, but they shouldn't do that actually, because they should operate in all circumstances. I think if no other reason not to operate it, they should operate. I mean, the serum creatinine itself by itself is not a reason not to operate.
Yes, okay.
We should not depend on the number.
The same problem occurs here in Egypt with the cardiologist. The cardiologist refer the patient where the patient is very stressing the doctor, the nephrologist. Please get my creatinine down. I want to do.
Be able to do an angio.
Yes, the cardiologist sent him and give me a drug now to reduce the creatinine.
Yes, yes.
Yeah, they shouldn't be doing that, of course.
Yes.
Okay. Thank you.
We have a last question, comment from the floor from Dr. Ismail Ibrahim, that he said that about the dilemma of CVP. ICU doctors are by now having a lot of methods in ICU settings to assess intravascular volume. Of course, this, and we have Dr. Mona mentioned one of the most important intraoperative that Professor Halawa mentioned, also esophageal, use of esophageal Doppler. This we have no more. We have no more questions on the chat, and excuse me, Professor May, to ask a question.
Thank you.
Professor Mona, yes, I want to ask a question.
Yes, please.
Professor Mona, you said that about a functional assessment of cardiac patients. You said that you use MAT score. So what about the use of ejection fraction for assessment of functional cardiac functional status per se as the only method?
Ejection fraction, you mean as a measure of heart failure, if it is less than 35, for example? Yes, but this can be evident in the very beginning. We do usually an ECG and echocardiography, and this will be evident in the echocardiography from the start. And then the patient is categorized not as normal. Then he will not go to the next step. I mean, the MET is done when we find that the patient has a normal ECG and echocardiography. So we do the MET in order to assess the patient if we need more in details, or more in the next step. Because this is also different according to the different stages. In patients with on hemodialysis, for example, it is a case different in chronic transplant recipient. We have to assess the heart very precisely. In patients with chronic kidney disease, there is a spectrum with patients with grade 1 and early stages, I mean, and end stage and hemodialysis. In patients with hemodialysis are much more risk. But if the patient has a low ejection fraction, that means from the start that he is a cardiac patient.
No need for assessment or scores or further.
Yes, that means from the echocardiography, if he has to.
Yes, and your cutoff point is 35?
35, I think, means heart failure, that the patient is high.
Yes, it's low. I think it's low.
Yes, it's low.
Okay, we have no more questions, and we have no more comments, Professor Mike.
Thank you very much. Thank you all for attending, and it was really very amusing discussions. And thank you, Mona, for the excellent presentation. And thank you, Yasser, for the whole thing. Thank you very much. Thank you all. And meet you next time, inshallah.
All my professors. Thank you, all our colleagues, attending colleagues. And excuse me to close this very fruitful session that lasted till late night, and announce about the coming meeting will be next Wednesday as usual. Will be Professor Ahmed Aql and moderated by our great Professor Muhammad Subh about kidney journal updates. Hope to see you again and see all this fruitful scientific gathering again and again. And excuse me to close.
Thank you.
Thank you very much.
Thank you.